All right, Landon, hit the disclaimer.
Back with Dr. Winge. He's agreed to meet again, and I'm going to kind of cover anabolic use, the risks with them, kind of how there's no free lunch. And I think he does a great job at presenting them in a non-judgmental way. And this is not a try to shame someone or fearmonger them. It's just, I want people to be aware of the risks of what they're putting in their body, and I don't care what people put in their body, and I'm not going to judge you for doing it, but I just want people to know the risks whenever kind of social media almost glamorizes them, and even the gym bros make it easy. It's an easy sell for them. Take this and you're going to get cut bigger, stronger, and just hang on, and so they almost don't go through the side effects or any monitoring with them. So thanks for coming on.
Thanks, Mason. It's been a while. So I'm glad we got to do this.
Yeah, I've been trying to figure out what to talk with you about. So
thanks. This is a good topic, like harm reduction, sport TRT, kind of the little more fringe topics are good. Because there's a lot of guys that end up going down this path, right? There's a lot of guys that do this, or they dabble, in this stuff outside of what you and I would consider like strictly hormone replacement. They are taking things one or two steps
way over,
over, right? Yeah.
Yeah. And so I'll say I've had this presentation kind of several times. What I'm going to give is kind of the most exaggerated one, but it's a guy who like starts to get himself back in the gym. He is, lifting weights, doing well, wants to progress more. And then he starts working with we'll just say a gym bro. And the gym bro, is like, hey, here's some extras to kind of help out. And there's no discussion of like fertility or what this does to your heart, but they sell it as like, hey, start this testosterone. This is good. This is your base. And then start this adjunct, start that adjunct. And so, like the one I had, the guy put him on 500 of testosterone right out of the bat, 250 of Tren, 50 of Anavar or Oxandrolone, and also cabergoline to help with the prolactin and everything. But this guy had amazing strength gains for a month, tore his pec off the bone, and then came to me and was like, hey, I'm going to do this, but I'd like to do it a little bit more safely. And lipids were out of whack, pre-diabetic and everything.
Yeah.
So,
he's pre-diabetic too.
Yeah. And that was even, he wasn't on GH or anything to cause that. It was just starting metabolically unhealthy. So he's just pretty much doomed for a bad time overall. But there are, a lot of primary docs don't know what these compounds are, what to look for, what to do. I think it's going to be good to have some information for these guys from somebody like you who, provides info in a non-judgmental way and everything. But PCPs, I do think they almost just shame, testosterone as a whole. What have you seen in terms of like bodybuilder management, risk mitigation, and kind of testosterone? Have you had similar presentations?
Oh yeah. I mean, I see the same guys, all the time. And just to answer your last question, of course, PCPs, they don't know anything about these compounds, let alone testosterone. I mean, they know nothing about testosterone, so it's not really fair to expect them to even have ever heard of Trenbolone or any of these other derivatives. So, they understand them honestly in the same way as like the general lay public does. They're just like, oh my God, whatever this is, it's bad, don't do it. But they can't give them any like meaningful advice. And, the fact of the matter is like, I mean, this just from the regular medical world, people that use substances, and I'm referring to just everything in general, whether it's anabolic steroids, or if they're like on opiates or cocaine, or, they smoke cigarettes or they take too much nicotine, you wagging your finger at them and lecturing them, that's not going to move the needle. Like, that's not going to make these guys, they're not going to leave your office and be like, oh, Mason's right. I really shouldn't, smoke cigarettes. They might, but, it's just not effective, right, to approach it that way. So the fact of the matter is, like, these gym bro guys, they're not going to come off of anabolic steroids because some family doctor or internal medicine doctor at a routine clinic visit, scolds them about their drug use. Like, it's just not realistic. I can't tell you how many people I've done like smoking cessation counseling on in the clinic, in the emergency department. And I almost don't waste my time on it anymore. I mean, we'll have just a brief conversation, but like, they're not going to quit until they're ready to quit. And so sometimes that just can take some time. Sometimes there's a major health scare that spooks them and then they'll come off of it. But, a person has to be ready to make that change. So that's in terms of the PCPs. They're very little help in this area. And then when it comes to harm reduction for someone who's like, listen, I'm not coming off of these drugs. Again, they don't really understand what to do. They know that there are risks, but they don't really understand how to mitigate those risks and what advice to tell these guys. And because it's difficult. There's not a lot of literature on it. So, but guys like you, what you just described are very common. I mean, all of us want to get from point A to point B as efficiently as possible. And, it's unfortunate that guy right out of the gate, ran into this guy at the gym and got him going down that path, because I'm going to guess this is a guy that was probably brand new to training. You mentioned he's pre-diabetic, so he hasn't built any of the healthy lifestyle habits first. Probably doesn't know the first thing about training, doesn't know the first thing about diet, and yet right out of the gate, he's been put on like a solid bodybuilding anabolic cycle. Like, I mean, of course that's going to go sideways. That's going to, and that guy wasn't doing him any favors by doing that. It's one thing to do stuff like that. If you've got 5 years of solid training under your belt, you know how to diet, you know how to exercise, you're in excellent metabolic health, and then you want to jump on that sort of a cycle. I mean, it's still a bad idea in my opinion, but that's a different animal than this guy who literally he knows nothing. And on day one, he's been put on, like, he's given a massive androgen load. His body's not ready for that in any way. And even like TRT might be something that he needs to like slowly phase into if he's not metabolically ready for it. So
that's what I was going to say. Before testosterone, I'll do almost like a, 3 months of lifestyle changes, right, so that they can accept TRT, not even just a full-blown steroid cycle, because
precisely.
Sometimes they can't handle the side effects if they're not metabolically healthy. They're poisoning themselves with alcohol every night. They have bad sleep apnea, et cetera, et cetera, et cetera.
Yeah, exactly. Exactly. So it's a problem.
So I kind of wanted to kind of tackle each one, just to, if you have any experience with them. If you don't, we can kind of move past them. But like each one just seems to have, a benefit that somebody says they're going to get out of it. But then they all seem to have some sort of drawback. And so I just kind of wanted to kind of give out just some information on kind of how there's no free lunch with any of these. And so I'd like to start with just the oral 17 alkylated, Oxandrolone, Stanozolol, or Anavar, Winstrol. Do you have any experience with them? Have you seen any? So
I don't prescribe them. And I'll say quite honestly, like I'm not an anabolic steroid expert. I know some things, but I'm not a vigorous Steve. There are a lot of guys in this space that are like true subject matter experts, and they understand the nitty-gritty of pharmacology, deep into which is cool. Like I watch their stuff too, and that's actually where I learned some of it. But in general, I mean, I don't use those in my clinical practice. But, all of these drugs, all of these anabolic steroids that are out there, at one time they were created by pharmaceutical companies to fulfill a certain purpose, like many of them back in the 60s and 70s. So, they were being used to treat like aplastic anemia and myelodysplastic syndrome, so like bone marrow issues, people with severe anemia. If I'm not mistaken, like Anadrol was used for like end stage breast cancer, in addition to like its bone marrow indications. So all of these drugs they were created for specific medical reasons and then abandoned because they either had, significant side effects, or in most cases, like we've come along with better things, right? We have better ways of stimulating your bone marrow than 100 milligrams of Anadrol 50 a day. So, you know, and Oxandrolone is one of those drugs as well, although it's obviously way less toxic than many of the other oral agents. I mean, it's used. It's not so much anymore, but like 20 years ago, when I was in burn units, it was prescribed in burn units, you know, to help with, you know, people that have severe burns enter into a hypermetabolic, like hypercatabolic state. And, you know, it's bad enough when you're bedridden in the ICU, like you're going to lose a ton of muscle mass, but people with large total body surface area burns, like that metabolic process is really accelerated, and the muscle tissue just melts off of them. So yeah, I mean, you find papers on it, and you know, it has been used therapeutically for that. It was, you know, used like in the AIDS epidemic for cachexia and HIV associated muscle wasting, and like, yeah, it definitely has some benefits in those areas, but we just don't see it used very much anymore because we have better therapies for that kind of stuff. But now, like, I bet the majority of Oxandrolone that's prescribed by physicians in the US at least probably comes from TRT clinics. I don't have data to support that, but I think if you looked at all of the prescriptions, they're probably mostly coming from these, you know, men's health / optimization clinics. And, you know, they're really, in my opinion, there's not a good compelling medical indication to prescribe Oxandrolone, let alone, you know, stanozolol or Winstrol. Nobody has an Oxandrolone deficiency, right? Nobody has an Oxandrolone deficiency. And quite frankly, like, I think it's prescribed because patients request it. It's a highly anabolic, it's oral. So, you know, the delivery method is easy and acceptable. It's relatively inexpensive. And I mean, let's face it, if you're on TRT and you take an additional load of Oxandrolone, you're going to get better gains in the gym. So it's largely for cosmetic reasons. And what you'll see is, like, people will say, oh, well, no, it's my SHBG is too high, right? So I needed Oxandrolone to lower my SHBG. I'm like, did you really? It really, that's what you need to lower your SHBG? Okay. Like, maybe more testosterone, you know, which is a bioidentical natural hormone that, you know, your body knows how to deal with, that the metabolites of testosterone have, you know, real therapeutic effect, as opposed to this oral synthetic, which does stress your body and creates unnatural metabolites. Maybe the testosterone would have been a better way to do that. So I'm not a fan of these drugs, but, you know, I'm also like, I'm really big on not scaremongering, because let's be honest, like, if you want to run a little bit of Oxandrolone a couple times a year, and assuming you're otherwise, you know, your liver is healthy and your rest of your physiology isn't too skewed, I mean, it's probably okay. It's just don't fool yourself into saying, like, this is not going to extend your life. Like, Oxandrolone is not a life extension drug. It's
like that. Yeah.
At best, it's neutral, right? At best, it won't shorten your life if it's used judiciously. But there's a reasonable chance, if you use it excessively or for prolonged periods of time, it could shorten your life, like, over the years, if you continue to use it. So, you know, I'm into health and longevity, and that's what I'm interested in. So if, you know, anybody that works with me, that's what we're going to focus on. I want you to get jacked and tanned as a side effect of being healthy, right? Yeah. I want you to have a six-pack as a side effect of being optimally metabolically healthy and extending your lifespan. It's, you know, my primary purpose is not to give you a six-pack or an eight-pack, even though I totally support you if you want to have that. I want to have that too. But there's a way to go about that. And that's the thing too, like, your guy that came to see you, you know, ultimately, like, I don't know how much extra muscle mass he put on in that whatever period of time. It was probably a reasonable amount of muscle tissue. You can't tell me that if he had just been a little bit more patient, if he'd learned how to dial in his training, if he'd learned how to eat properly, and if he was put on a more reasonable replacement, even like sport TRT, which we'll talk about, you know, regimen, that he could not have achieved. He probably could have easily achieved the same, like, gains. Maybe it would obviously take a little bit longer, but he could have gotten those same gains, experienced none of the adverse health effects, and maybe he wouldn't have torn his pec. as well. So at the end of the day, like if he had taken that more reasonable approach and focused on the lifestyle and the training, like you can get those results. It's just you have to be patient, and guess what? You have to work a little bit harder to improve your knowledge, and you have to be a little bit more diligent, but you can still get outstanding results. I mean, you and I have seen this. You can get outstanding results on TRT if you put the work in those other areas. What a cycle like that does is allows you to be sloppy, right? You can be sloppy in your diet. You can be sloppy in your training. You don't have to try that hard to educate yourself and learn new things. The gains just come. It's just cool. Like I don't have to, I can eat ice cream and get jacked. Well, great, know, but is that really sustainable? Is that really the smart way to do it? I don't think it is.
Yeah, and so that's my practice too, is just like, look, what I'm trying to put on you today is to keep you to where you're healthy, active in your 90s, and like you're saying, it's not a longevity promoting. I don't prescribe it either, but what I've seen when guys come in on it are, elevated LFTs, their HDLs get dropped pretty low. Well, you had a ER case with Oxandrolone.
Actually, well, it was Anadrol ultimately.
Oh, was it? Okay. What they had, the hepatic cysts.
So this guy had pileosis hepatis, which is a ultra rare liver condition where you get these big blood-filled sacs and cysts in the liver. And they're associated with oral anabolic steroid use, but there's other drugs that cause it too, like birth control pills in women can do it. SERMs can do it. So there's tons of case reports of women with breast cancer on tamoxifen, and they've come in with these big blood-filled fluid sacs, and sometimes they're relatively small, but they can get really huge. And if they rupture, like it did in this guy, like one of them was, is at the surface of the liver, is right, up against the capsule. And, I don't know if it ruptured spontaneously or he had a little bit of trauma or whatever. The liver gets a lot of blood flow, right? Like you can bleed out from a liver laceration easily. Yeah. I've seen it many times in trauma cases. So and this guy started to bleed blood. He had blood in his abdomen from one of these cysts that ruptured. And, he obviously I got him to the CT scanner fairly quickly, and that's what the diagnosis was. So
that's wild.
So that's a rare complication of high doses of prolonged, 17 alpha alkylated oral steroids. Like that's a thing. And this guy was young, super fit, but and he was pretty jacked. I'll give it to him, but not. He wasn't super jacked, not
enough to justify.
Not enough, like this guy, he certainly wasn't getting paid to be jacked. So this was just for cosmetic reasons. And, I didn't have time to get into, why he was doing this and all this sort of stuff. Then there was a language barrier too. Like his English wasn't very good. So everything was going through a translator. I have to do that quite a bit here. But again, I was looking at his physique. I'm like, dude, you could have gotten this with 200 milligrams of testosterone a week. It just would have taken you a little bit longer, and you would have had to been a little tighter on your diet. And I'm pretty sure we wouldn't be meeting under these circumstances if you had done that. So he could have died. He literally could have bled out, from that. So again, super rare. Again, I'm not trying to fear monger, but
super rare.
This is the shit that can happen to you, right?
And things do happen. Thing. I mean, the ER is the spot where I have to pull myself back a lot of times because I'm overly cautious with some things. I mean, I'll say a post tonsillectomy bleeds. My kids, I'm like,
those scare me.
I don't want them to get
me too.
A tonsillectomy, and I don't know the exact statistics, but it's probably 1% or less.
Yeah, it's super low.
Almost never happens.
Right.
But who sees it is the ER. And
I know,
so it's I've seen
we're totally skewed, right?
Yeah, exactly.
Yeah. We're all Chicken Little, right? The sky's always falling. But the thing is, in that environment, where I work, I have to keep my head on a swivel every day because in a big urban like level 1 trauma center, the weird shit that, and we can talk about this, later. And I saw in the notes every single day there's some weird thing from a textbook that comes in that I've never seen before, which makes it kind of interesting. So if you only worked at places where I've worked, you would think that like everybody has aortic dissections, everybody has meningitis, everybody has everybody has dengue fever. I had a case, we had falciparum malaria, a guy with like fulminant falciparum malaria come in a few days ago, just sick as shit.
Oh my gosh. Do you have the CDC to call in?
We have, there's a Department of Health here. And so, and they're very good. It's just, like this country is, it's kind of at the center of the world. So people from everywhere come here on airplanes. And so whatever weird tropical disease that exists in their home country, they get to bring it and they land on my lap sometimes. And so I get to see that. So you're like I totally agree. Like my view of the world is skewed,
No. Yeah, I've had malaria here in Texas from a traveler,
for sure.
Come in.
For sure.
It's
totally
like
happens.
I never thought it would happen in this little town or anything.
Yeah. Like
you
I
see
had a
weird
crazy
stuff.
tuberculosis case recently. We've had 3 meningococcal meningitis cases in the last 4. A couple of them died.
It's terrifying.
Anyway, not to go off topic, but we see weird stuff, right, in the department. It's just how it is. So.
Kind of getting back, you mentioned synthetic, that these are synthetic. And so I view it a lot like, and this could be another deal, and I'll try not to get off topic again, but like the WHI and the Women's Health Initiative for women,
same thing.
Like they set this huge fearmonger of hormones because they use synthetic conjugated equine estrogen, medroxyprogesterone acetate. Those risks are not translated whenever bioidentical estradiol and microdose.
In fact, it's opposite. It's opposite.
It's protective.
It's
breast
protective,
cancer
right?
protective.
Same with progesterone. Progesterone, yeah.
We just don't have the receptors for this synthetic stuff. And like you mentioned, the metabolites, which are in testosterone, are beneficial. They're a feature, not a bug of testosterone therapy.
Exactly. Yeah, they're probably responsible for the majority of the positive effects is the metabolites, right? Yep. And, everybody metabolizes these in slightly different ways. These enzymes are all genetically encoded. And so you might get a little bit more of this, a little bit more of that. But with these synthetics, those same enzymes chew up on these synthetic compounds. But what comes out the other end is not, something that's bioidentical. It's going to be a little bit off, and so it's going to have slightly different physiological effects. And depending on the context, sometimes that's positive, but oftentimes it's negative. So that's one of the issues, right?
Kind of the next one that I'd say is super common that I probably see the most are the 19-nors. So Nandrolone, Trenbolone. I want to kind of touch on Nandrolone a little bit because of all of them, it probably has the closest medical justification.
It does. Kind of.
Kind of. Like I've wrestled with this as just as a clinician for a while. Like, can I justify bringing it on? Is it worth it? And ultimately, due to the endothelial health and me really focus on longevity, I don't offer it. But I can see. Like I'm going to give an example of shoulder pain where a guy's living on 800 of ibuprofen multiple times a day, NSAIDs, and they don't need tons if you're responsible about it and you do like low dose Nandrolone. The street name is Deca. But that joint pain can be controlled, and if they're trying to put off surgery for 6 months or so, it may actively help prevent that surgery, but at the cost of endothelial dysfunction. But I just kind of I'll stop my rant. What is your experience with Nandrolone? What do you think about Nandrolone? Yeah,
it's such a good topic, and it's totally nuanced. I was on low dose of Nandrolone for a while. Now I've been off of it for about 1.5 years, maybe 2 years. One, it's not available here, and then I do have some long-term concerns about the cardiovascular aspect of it. It's a bit of an unanswered question. Like, at least at the doses that we're using for pain control,
Right.
we know that from animal studies and human studies that the higher doses are they're universally associated with adverse, cardiac remodeling, problems with the electrical system of the heart. It's just not a good thing to be running 200 milligrams plus of Nandrolone into perpetuity. The problem is, of course, like you said, it does work. It does. And there's data for it. It's not the world's best studies, but the anecdotes I think are real. Our guys talk about the joint relief. And, as somebody who suffers from chronic joint pain, if you don't have chronic pain, you can't really understand how severely that impacts your day-to-day life. So people that have, not just chronic musculoskeletal pain, but people that suffer from neuropathy or any of these other chronic pain syndromes, people with rheumatoid arthritis and psoriatic arthritis and stuff like that. It's so debilitating. It's pain that, I can remember in the last year before I had my back surgery, I was in pain every single day. I was never less than a 4 or a 5 every single day. And it was 24/7. And it was one of those things you can't escape it. You can never, I was chewing NSAIDs like nobody's business and taking acetaminophen and things like that. So it changes your personality. It makes, it made me a little bit grumpier, honestly. I just was less empathetic to people that came into the ER with back pain because I'm like, well, shit, man, I can barely walk. I can't feel my right leg at all. And I'm here working, what are you doing here? That sort of thing. I was pretty abrupt with my partner at the time. It changes you. And so I understand, chronic pain is serious. It needs to be treated. And so I totally get if guys, they get on Nandrolone, they're like, oh my God, I feel so much better. Cause I did too. I could sleep at night. I've got 2 really bad rotator cuff tears and that immediately started feeling better. So I understand the appeal. And I don't cast judgment at all. As somebody who's had chronic pain and still deals with chronic pain, I get it. You do what you need to do to relieve that and, get on with your day. Having said that, it should not be the first thing that a clinician reaches for. It's not even the third or maybe it's the fourth thing. But I'm not going to entirely rule it out. There are people that benefit greatly from low doses of Nandrolone. And just like you said, I mean, everything is a risk benefit trade-off, right? If you were on, let's just say 25 or 50 milligrams of Nandrolone with your TRT for 20 years versus you taking 600 to 800 milligrams of ibuprofen 3 times a day for 20 years.
Yeah. And I think
what's the outcome there, right?
Yeah. NSAIDs and heart decline,
nasty.
I don't think
they're not good for your heart. They're bad for your kidneys.
Talked about enough.
They're bad. Getting back to the ER, I can't tell you how many misadventures I've seen that are related to NSAID use, GI bleeds on a
Vomiting
regular basis. Yeah, exactly. Upper GI bleeds all the time. People are coming in with, with kidney failure, that sort of thing. And in the mix there is chronic, NSAID use. So, it's an unanswered, nobody's studied what 50 milligrams of Nandrolone will do for you, or to you over 20 years. You're just not going to have that data. So, what I would say is, listen, if you really genuinely feel like that's what you need for your quality of life, and you have tried all these other modalities for pain, and I don't just mean pharmaceutical approaches. There's a lot of ways to treat chronic pain. Honestly, one of the, and still is the best thing for my back pain when it flares up, is my TENS unit. I use a TENS unit. So that's, for those who don't know what that is, it's it's a muscle, those electrical muscle stimulators, right? So I put the pads on my lower lumbar spine, those paraspinal muscles, and honestly, I wear it when I work. So it's discreet enough that I can have it on under my scrubs, and I just put it in my back pocket. There's a little wire that comes out. Nobody even notices it. And I'll run that thing on a 10-hour ER shift when I'm on my feet constantly. Honestly, that worked as good or better than, it definitely actually worked better than NSAIDs and acetaminophen for me. And so, there are other pain modalities, even acupuncture, massage, other sort of stuff that you can use. But let's just say you've done all of that stuff and you're miserable, your quality of life is poor, and you want, and like Nandrolone is the thing. Like, you're like, listen, I want to stay on this. It's, my quality of life is so much better. I'm not, who am I to point a finger at you, right? To say you shouldn't do that. What I do think you should do is have proper medical supervision. So, what does that look like? I mean, we know it has a number of potentially serious adverse cardiac problems. So cardiac remodeling, meaning like left ventricular hypertrophy, which, if that goes unchecked, can lead to heart failure. So something called heart failure with preserved ejection fraction. So you get a thick, dysfunctional ventricle, it becomes stiff, so it gets fibrotic. So your heart needs to relax to fill with blood in order to, keep pumping it forward. And, high doses of Nandrolone, especially in animal studies, that seems to be impaired. So, you need regular echocardiograms. You need to have your blood pressure meticulously under control. You need to have your lipids meticulously under control. It affects the electrical system in the heart. A lot of people don't know this. So it prolongs the action potential, which is the little electrical signal in the myocytes. So at the very least, like, you should have a baseline ECG. There's a lot of people running around with what's called like prolonged QT syndrome. Right. Yeah. So you'd want to know that. Like, if you had a prolonged QT or some other like rhythm disturbance, you may want to think twice about that. Or you may want to just stick to the absolute lowest dose possible, which honestly probably most people should do anyway. So there just needs to be, it's not something you just want to it's not fire and forget, in my opinion. So if you're going to go down that road, like, work with a doctor, whether it's, a primary physician, someone like yourself who, comes from ER and primary care like I do, but who also knows about this stuff, or a cardiologist who's, on board. Somebody who has some expertise in keeping you safe and healthy. You don't want to just fire and forget if you're going to use Nandrolone. So that's kind of how I feel about it. Like, I'm wary of it. And again, I stopped it myself out of these same concerns, even though I've done all of my due diligence, including an echo and all that stuff. I got young kids and I want to live a long time. So trying to deal with my chronic pain in other ways. So that's a pretty long-winded answer. Like, I'll never wag my finger at somebody who says they need to take Nandrolone if they have legitimate joint pain, but please exhaust like all of their options before you consider that. And that's not what happens, unfortunately, right? Like, your guy, like on day one, if he had gone to see some other provider other than you, they would have been like, hey, sure, here's your 200 of testosterone, and why don't we get you on 100 of Nandrolone too? We'll just right out of the gate. Yeah. Like, they're just quick to prescribe it. It's the same with Oxandrolone, right? They're trying to make a buck, and they don't really have your best interests at heart, I think.
And even from a clinician standpoint, honestly, it would be fun to prescribe them. If I had the medical justification, I would be like, heck yeah, sure, have at it. But, it's like, no, again, my main goal is I want you to be functional, healthy, happy at 90, 100. And these are, again, just not longevity.
And, the other thing too, like this, obviously, and this is another part of this for us as clinicians, if that person that you have on 50 of Nandrolone, if they have an adverse event, which, all of us are going to have adverse events at some point in our life. Yep. What is going to get blamed for that, right?
Yep, exactly.
And they're going to look at who prescribed that. And, like, you put yourself at medical legal risk as a provider doing that, which it blows me away, like, how liberal some of these, I call them clown clinics. I mean, they're just like handing out Oxandrolone and stanozolol and all this stuff without a second thought. And they're writing it in huge quantities. I'm like, do you not care about your medical license, man? Like
I don't know how they do it,
you're going to get fried. You will get fried by a medical board if there's ever a complaint, because it's you're going to have a really hard time justifying it. Like the few times that I've prescribed Nandrolone over the years, like my documentation is wired-tight, it's, and even then I don't feel like I could still potentially have scrutiny. Like some endocrinologist could get up in front of a medical board and say that I'm the worst doctor ever. I could lose my license over something like that. So, providers we need to think about that stuff. I don't think we think about that enough. It's unfortunate, but that's just the climate, right? Especially in the United States.
Yeah. So. Yeah. Have you ever used low-dose naltrexone for any chronic pain
so
on yourself?
I haven't. I have not. Personally, I haven't used it. I haven't prescribed it, but that's one we talked about this offline, right? That there's some data, but the first and foremost thing that I look at with all of these things that are, a little bit more in the functional medicine world or like a little bit quote, alternative, not mainstream, is it safe? And that's one like clearly pretty hard to hurt somebody, right? With naltrexone. And so I'm 100% open to trying it. If I get somebody who has like severe Crohn's disease or has some other syndrome like that, right? Like any of these like difficult to treat, inflammatory bowel disease, etc. Yeah, I'm completely open to trying that because I feel good. Like it may not work, but I know I'm not going to hurt you with it.
Yeah, exactly.
Now the majority of people that like, I always ask, like I've got a good buddy of mine who's a PhD pharmacist, very knowledgeable on this stuff, and he takes it. What have you noticed with this stuff? He's like, honestly, nothing. Like I've been on it for a year. I can't tell the difference. I can't. He put his father's like in his late 80s, early 90s, and has like chronic pain issues, and he's like, and is a retired physician himself, and he's like, yeah, I can't tell any difference. But there are people like in these subcategories, like you mentioned, with bowel disorders and stuff that do benefit from it. So. Yeah, that's a different thing. It's first do no harm, sure. Just like we talked about. If something is out there that, maybe the data is not the best on it, but like there's no reasonable like reason to suspect that there's going to be harm from it, I'm totally open to talking about it. Yeah. I'm not going to slam the book on it like, other physicians would. So.
Yeah, and I forget the exact mechanism of this, but I think it's something nitric oxide related with Nandrolone. If you don't do a proper testosterone to Nandrolone ratio, you get the street name Deca dick. But, I think it's something with the nitric oxide production, which nitric oxide is so important to endothelial health, blood vessel. And I'm always trying to optimize my nitric oxide, and I don't want to jeopardize that in anybody else. Yeah. But I forget the exact mechanism with that.
Yeah, I do too. That's part of it. That's one of the ways that it helps. People talk about it like joint hydration and all these things. The truth is, I don't think anybody really understands the mechanism, and it's probably multiple mechanisms by which it's effective. But almost universally, people that I've spoken to that have used it are like, yeah, it helps. So this is one area where like the bros were ahead of the bodybuilder bros since the 70s, right? Have known about the joint effects of Nandrolone, right? And it's only since then that the medical world has slowly caught up. So this is one area where they were way ahead of us on that.
Yeah. So I'll switch gears to the easy one in terms of just negativity. Is in the 19-nor category is Trenbolone.
Oh, Tren.
Trenbolone sandwiches, Trenbolone sandwiches.
Trenbolones, yeah.
Yeah, because I see the appeal, but my God, totally. Is it hard on every body system? Nothing else grows and cuts like it, but it's not a human drug ever. It's a veterinary. Yeah. Two, the heart is probably the worst, the paranoia, the hypersexuality, the, kidneys, liver, it just hits it all. So this one is a much easier one. It's just like, I can uniformly and confidently say, please stop giving in to Tren.
I agree. And like you see stories, high school kids that are getting hold of this stuff.
Yes. Golly.
And who knows if it really is like there's no, to my knowledge, anywhere worldwide, there's no legitimate pharmaceutical company that makes Trenbolone. So it's all underground. And so, not only do you have the toxicity of the pure drug, but like God knows what else is in that vial, right? If it even is Trenbolone, you don't know. So, you're injecting potentially a bunch of impurities and inflammatory substances, which are probably compounding, the negative effects. So, yeah, it's the way I look at it, like if you're getting a paycheck from bodybuilding, okay, I get it. Yep. If you're feeding your family, if you're right, like if you're on the Olympia stage and in order to feed your family, you need to take Trenbolone. Okay, I understand. Like, please just be smart about it. But anyone, literally anyone else, like, I'm just like, what are you doing, man? Again, most of the guys that I've run into that are on Trenbolone or taking Trenbolone have mid-average, what I consider to be mid-average physiques. Above average. The average is pretty bad these days, so they're above average. But I look at them and I'm like, listen, man, like with 1 or 2 years of extra just training and figuring out how to train and get your diet, like you could probably get similar results, right, without any of these negative side effects. But it's the fast train, right, to looking, to getting to gains. There's no question that that's why it's popular, right? It works. Yep. But man, the toxicity and then the fact that like teenagers and guys in their early 20s, before your frontal lobe is like fully developed, to be injecting these kind of substances, it's just a terrible idea. The long-term ramifications of that are, I think there's no good that's going to come out of that. And, when you discontinue it, are you going to be able to even maintain those gains that you got transiently, right? Yeah. So that's why I said, like, if you need it for a contest, if you're a professional bodybuilder and you need to win a show, okay, like take it, you're going to take it for the show, but then for God's sakes, like come off of it. But the rest of these guys, they're using it year round or they're just doing cycles, and they have no intention of ever competing, no intention of doing anything else. They just want to look good, which again, I don't fault anybody for wanting to look better, but let's be smart about it. So it's a terrible substance. Some of the worst lipid panels I've ever seen in bodybuilders, it's all come from Tren. We're talking like LDLs, 300-400, single digit HDLs. Yeah, exactly. Single digit HDLs. CRPs through the roof, because the other thing too, like nobody takes just Tren, right?
Right.
It's always Tren plus. Certainly, there's a testosterone base in there, which, quite frankly, I'm not that worried about. But many times it's like a gram, which I am a little worried about that. Yeah. And then they're taking like multiple other things. Primobolan is in there, and all these other equipoise and all these other things that are in the mix too. And so the synergy there, in terms of adverse effects on your metabolism, your lipids and liver health, and God knows in your brain, God knows. So anyway, I'm not a fan. I mean, I do it if you feel it, again, do what you want with your body, but fuck, I would stay away from that one.
Yeah. You brought a good point, the underground stuff. I meant to bring it up in like the introduction and everything, but I think the underground stuff, it has its own negativity. And now that, research chemical peptides are becoming popular. Yeah. I think that is also underplayed, because completely. You're relying on that somebody else knows sterile technique, knows math, knows how to do basic chemistry.
They don't.
And will put the same compound that you're wanting in there, and so it's like, it could literally be cousin Ricky making it in his bathtub, Rick Collins is the lawyer for the Fit and Jacked, and he says, I have seen the body cam police footage where they raid these guys selling it online, and it is a literal, in the bathtub that they're drawing out and injecting. And so, in the ER, I've drained abscesses from bunk gear and everything. I've never once done it from a legitimate compounding pharmacy or, commercial stuff or anything like that.
No, I have two. In fact, not that long ago, I had a guy, very jacked guy, who had a horrible cellulitis, actually, that was all in his arm. And it was started, he did a deltoid injection, and he had raging cellulitis. And he was sick enough that I wanted to admit him to the hospital. He was actually septic. from it. But he signed out AMA, against medical advice. He's like, nah, just give me the pills. I'm out of here. I'm like, all right, good luck. Now I didn't see him back, so I'm assuming he survived. But yeah, man, that's like, you don't know what's in that vial, right? Like unless you send it off. And there are testing services out there if you look for it. Like if people want to find out what's in their gear, you can pay. There's a guy. I need to talk to my friend Daniel because he knows this guy. But there are legitimate places you can send these substances and find out exactly what's in the vial if you want to pay the money. But nobody does that, or very few guys do that. So it's a crapshoot, right? Like your underground lab, it could be quite good. It could be squared away and hygienic, but like you said, these are underground. Their primary purpose is profit, of course. So do I trust them not to cut corners? No, of course not. Of course not. So first of all, what you're injecting, it may not be sterile, right? Like you might have Trenbolone and a solid dose of Staph aureus and E. coli and God knows what else, MRSA and VRE and God knows what else floating around in that vial. You may have, very inflammatory carrier oils that are going to also cause problems. So you just don't know, man. It's, could be, you could catch hepatitis, or whatever, like there could be an infectious disease in that thing. You just don't know. So
even the chemistry
beware, right?
Even the chemistry needed, like some of these will have like endotoxins or heavy metal contaminants.
Correct.
And like whenever it's a legitimate pharmacy and stuff, they actually take measures to prevent that. And
by law, they're required to. They're required to. And they do. Yeah.
I think testosterone has gotten a bad rap, and we're still fighting the stigma with it, and it's because of this kind of unregulated stuff that you do see the bad effects, and all of that for the longest time was just extrapolated to all testosterone use, not just anabolics and everything.
Well, getting back to the primary care physicians, just like with Women's Health Initiative, right? They conflate oral estrogen. All estrogen is all estrogens, right? So they don't understand that there's actually a difference between the stuff that's in oral contraceptives and Premarin, then that's not the same thing as bioidentical E2, right? Oral estradiol. And it's the same with testosterone, right? So most physicians look at Trenbolone and they're like, that's the same as testosterone. So testosterone, and it's like, no, man, like these are totally different drugs. And I understand that they look the same on paper, kind of, like they have the same steroid backbone, but like, come on, you're a doctor. You should be smart enough to understand, like, changing a methyl group makes a big difference, physiologically. But they just, in their mind, there's these are the same, synthetic progestins are just as dangerous and just as bad as, oral micronized bioidentical progesterone. It's like, no, actually, like, literally the effects are opposite. So, they just put it all together. So
one of the things, and I even want to get your take on this because I've heard, but GH, growth hormone, and the growth hormone secretagogues. So I'll say, like, I use the growth hormone secretagogues in my guys kind of as like the last adjunct, and as long as they have a solid workout regimen, they're working on everything. And they're not amazing, and that's really why I don't use them as like a solo agent, because if a guy's not doing the work, he's just not going to get much out of it, and they're already expensive from a compounding pharmacy. But I do use those. I don't use straight GH just from the guidelines of it, but it has its own risks or drawbacks. But what is your experience with the secretagogues now that they're getting more popular?
Yeah, great question. Yeah, so what you said about GH is totally true. I think we'll start with just like pharmaceutical GH. There are certainly, especially in older populations, there's no question, like there can be some benefits there, right? There can be downsides as well, but it's a slow burn. Like this is something that, the benefits start to show up 6 months, a year later. It's not a feel-good hormone. Like, You don't inject GH and be like, wow. Whereas opposed to like thyroid and testosterone, like you can genuinely, in many cases, feel the benefits fairly early on. GH is not like that, at least at like reasonable replacement doses. But, as you get older, like there are a lot of benefits potentially for body composition, for joint health, et cetera, even cognitive and cardiac function as you get older. And really generally, like the older you are, the more you stand to benefit. So, these guys that are taking GH and secretagogues under the age of 40 are probably not reaping the same benefits as like a 70-year-old that takes those substances, right? They at least based on the literature, they're going to get a little bit more out of that. So having said that, like as far as the peptides go, are they safe? Yeah, I think they are. But again, the studies are all they're all short-term studies. They're mostly animal studies, just like all of these peptides that are out there, and not just the GH ones. Like I want more studies on these. I think they have potential, but I really need like long-term safety data, and I want to know like what's the best patient population to use these drugs in, like, because not everything works for everybody, right? And that you can say that about any drug. You want to have the right drug for the right patient, for the right condition at the right time. And that's just in general. So same thing with these GH things. So I've used them too. I've used Somorelin, I've used Ipamorelin with CJC. And what I generally, and this is just my opinion, so guys can do whatever they want. I think they're good to help you achieve a specific goal, like for an intended purpose. So for example, like I tore my ACL and ripped up my meniscus, and I went in and had surgery on that. I used a 12-week course of Somorelin to speed recovery post-op. So if I was going to go in and have major surgery, I mean, there's good studies with GH showing that it can help speed like wound healing and recovery, like especially like after ACL surgery, rotator cuff. So like that would be an indication where you'd benefit from a little bit more growth hormone potentially, right? Potentially. Yeah. All of the studies are in GH. They're not with these peptides, by the way. So this is just like I'm extrapolating from those studies. If you're on a fat loss cycle, if you're very obese and you've got a lot of weight to lose, yeah, I mean, there's some potential there. I mean, that's partly what growth hormone does, is it helps with fat loss. And so that might be something like for a period of time that you would want to use it for. But just like adding it in perpetuity, 12 years, one, there's no data on it. And I just don't, like, I don't know what the long-term effects of that are going to be. Is there a potential problem with like constantly stimulating the pituitary with these peptides? My gut feeling is probably not from the short-term data, but like, again, we just like, it's an unknown for me. So I'm not adverse, to using them if there's an acute indication, but I would just say that guys, if you just want to stay on them forever, you're just kind of venturing into the unknown in that regard. Like we don't know the long-term side effects of it. And the final thing too is like, I don't know how much they're going to move the needle for you in terms of health and longevity. You will probably keep your IGF-1 levels right at towards the upper range of normal. But is that going to be adequate, or is that worth the price? Because like you said, I mean, they're way cheaper than growth hormone, but they're still not cheap. So I guess if you have the disposable income, okay, go ahead and do it. But is the juice worth the squeeze? Like, are you going to get that much more muscle tissue? Are you going to get that much more fat loss if you're dropping $300 a month on growth hormone peptides? I don't know the answer to that question, So it's an individual thing. I do think they're probably safe. My question is how efficacious they are. I don't know. I just need more studies on it. So that's just my personal. It's not evidence-based answer. I just use them for specific indications. So
yeah, one of the most popular, BPC, anecdotally, and we have millions of anecdotes. It's awesome. People report a lot of things. Man, I wish they would throw out some sort of human studies. There's like
I know.
And it's
that's the problem. That's the problem with all of these things.
Yeah,
and I did a big video on BPC, and like if you're a mouse with a tendon injury, it looks amazing.
Regrow it.
It's amazing, right? But
We just don't have the human studies.
Where's the
and
human
it's like,
data, right? And if you're going to get it, are you getting it from a gray market source that, may have the same problems that we just talked about with anabolics? So, yeah. Peptides are super interesting. I don't consider myself a leading world expert in peptides, and I think they have a lot of potential. I think they're probably, most of them we're going to find that they're relatively safe compared to other things that we use. We just don't have we just need data, and I don't know if we're ever going to get it. I don't know if big pharma is going to be, if they're incentivized enough to spend the millions and millions of dollars that we need to do the proper studies. I don't know that we'll ever see that. So
I don't know either, and it's an interesting time because, I'm sure gray market BPC is exploding, so it's they see everybody's volume, yeah. But I think it would be hard to figure out how to make a profit from the peptide, and so it's do we drop $1 billion to study it, go through the proper channels to be undercut by a gray market peptide that's already out there.
Exactly. So, yeah, and so that's the kind of, in the boardrooms of these pharmaceutical companies, that's the kind of math that they're doing. Pharmaceutical companies are greedy. They're in the business of making money. So, if something is out there that really works, they're going to turn it into a drug that they can profit from. Right. Yep. So all these supplements out there, there's people nattokinase is a good example. If nattokinase could reverse atherosclerosis and clear plaque out of your coronary arteries, you better believe that Pfizer and every other drug company out there would be marketing. They would take it and they would change one atom on it and they would patent that shit. And they would be making trillions of dollars off of nattokinase. They're not. You'd
give it to every ER chest pain.
Every chest pain, right? I mean, we used to give streptokinase, which was the first thrombolytic, but we stopped doing it because it was shitty. It didn't work that well, and we came up with better drugs. So, that's a kind of a good litmus test about a supplement. Is it really going to be effective? Well, I'd be has big pharma, tried to make money off of it? And if the answer is no, I mean, there may be other reasons, but it's probably because it doesn't work that great. Right. They want to make money. And if they're not going to ignore something that's super effective, like people claim it is, and not take advantage of that. That's been my experience with pharmaceutical industry,
Yeah, for sure. The last one, or the last kind of topic on them I want to talk about, is just testosterone itself. But, sport TRT or whatever you're calling it, where they want to run, way high super physiologic, and they want to keep your name on the prescription. But this is a very nuanced thing in a sense of how well do you respond? Where's the line drawn? Because I'll say, I have guys on 100 milligrams a week, split into doses throughout the week, and they run 1,200. I have guys on
I do too.
220 milligrams split doses throughout the week, and I can barely get them to 800. So it's not like there's a specific dose that now makes it sport TRT or whatever they want to call it. But where do you think that line lies between where we start going from optimization to now damage control or whatever, they start getting too bad of side effects from it?
Yeah, exactly. Your feed cut out there a little bit, so I didn't hear everything that you said, but I think I got the gist of it. Yeah, I haven't heard any, I don't know if there's a formal definition of what constitutes quote sport TRT.
Right.
So I'd be curious to see what your definition of that is. I kind of think of it as doses and levels that they're well above what a man needs to resolve his hypogonadal symptoms. They're well above what he would need to treat any underlying medical condition. So, let's say you're insulin resistant, type 2 diabetes, whatever you're taking, whatever dose that may be, whatever level you have is well above, you've sort of maxed out the effects in terms of that particular medical condition. And really you're taking levels that are primarily for purposes of physique optimization sports performance and essentially muscle hypertrophy. So you're well above the medical indications, and you're basically on it to put on additional muscle mass and to maximize like the quote feel good effects of testosterone. Like I've got a few buddies over the years that are bodybuilders that say they feel amazing on a gram of testosterone a week, right? They're just like, I feel like a god, I feel like Superman. And so they like that feeling, and which I mean, who wouldn't, right? But clearly like that's well above the symptom, whatever their symptom threshold was. It's well above, none of them have medical issues that I was aware of, but like well above anything that they would need to treat whatever medical condition they have. And so they're chasing the feel good parts of it. They're chasing the muscle hypertrophy. They're chasing the anabolic effects. And one of the reasons I think guys like sport TRT so much is that, I mean, it does allow you again to be you can be a little sloppy with your diet. You can be a little sloppy with your training, and the gains are still going to come a little easier. So you don't have to be as knowledgeable. You don't have to be as disciplined and diligent with your diet, and you can eat ice cream and sometimes be not as good as you should be on your diet and still like do well in the gym. You can still look good. You can go and like binge drink on the weekend, and you're still like Monday morning when you wake up, you're still going to have abs, that sort of thing. So I kind of, that's how I think of sport TRT. Do you have a definition?
No, this is kind of what makes testosterone treatment so nuanced, is because, there's not going to be a number that automatically switches from, now you're not in, replacement, because, like guys with highest HPGs, I have their testosterone levels
good example,
way high. Yeah. Their total to get a decent free testosterone where they get symptom resolution. So it's not going to be dependent on a number, and you're kind of hitting it right on the deal. It's like, okay, well, symptom resolution is at 150 milligrams a week. I'm not going to let you run at 300 milligrams a week. And now, potential for blood pressure being out of whack, acne, mood disturbances, et cetera. But some are just so sensitive, even I'll have a guy on say 120 a week, and I increase to 150, and then that guy gets uncontrollable acne. He gets mood
anxiety,
disturbances,
right? Panic attacks,
anxiety,
poor sleep,
and it's
all that
like
stuff.
He can't tolerate that, so it's crazy. Like, but some, and the bodybuilders are always great because they give us a, the extreme sample side. Some, they act like 500 of test a week is a baseline. Like that's just, nobody needs to be under that,
Oh yeah.
That's the starting.
I mean,
dose.
that's common, right? That's super common.
Yeah.
No, absolutely. It's absolutely true. So yeah, so that's kind of how I think about sport TRT. And again, there is no long-term data, right? So
exactly.
I talked about this in a video recently. If guys want to have a traverse level quality study on quote sport TRT, so even levels above 750, honestly, because was the cutoff in the traverse.
Yeah, you're right.
Like that's just it's not going to happen. Like you will forget it. Like big pharma is done. They're not. In fact, we're probably not going to have any more safety trials on testosterone because they funded that study and they got the answer that they wanted, and now they're just going to move on and continue with marketing and things like that. So, unless somebody comes in, from the private sector and coughs up a few $1 million, you're not going to get that kind of a level study on guys who are taking like even 300 milligrams of testosterone. So the best we can do, the highest dose that I've ever found in any clinical study is 600 milligrams. And it's that group of studies that I know you're aware of them as well. Yep. Most physicians and providers in TRT are aware of these studies, and they're generally with healthy men, various, both young and old. But, I think the longest one, I'm trying to remember, is 24 weeks, maybe longer, maybe 6 months at the most, something like that, right? So it was surprisingly well tolerated. And there really were not any, maybe I shouldn't say surprisingly, maybe it's not surprising, but yeah, I mean, there really was not their lipids didn't skew, their blood pressure didn't budge. There were, some guys had issues with water retention and things like that, and mainly in the older populations, but it was surprisingly well tolerated. But those are short-term studies, right? So if I get a guy that is doing, taking those kinds of doses, I'd be like, just please be smart, please be monitored, please make sure that all of your cardiovascular risk factors, and I mean all of them, are being managed by somebody who actually knows what the hell they're doing. And I hate to say it, but most of these TRT clinics are staffed by people that they have very little clinical experience dealing with coronary artery disease and heart failure and chronic kidney disease and all this bread and butter like internal medicine stuff that you and I see or you would see before we got into this field. So just be smart, like don't fly solo on this kind of stuff. But that's how I think. Like I don't prescribe sport TRT. I don't. But I do focus mainly, like you said. I mean, I focus mainly on symptoms. But there comes a point where, like, listen, man, like you're not going to tell me that you need 400 milligrams a week in order to resolve your TRT symptoms. Like, if you're still having symptoms at 300 milligrams a week, yeah, like maybe there's something else that's not testosterone related. Like, and that's why it's important to do a good history when you get a new patient, because most of the time this stuff is multifactorial, and patients come in with unreal expectations, right? They think testosterone is going to solve all of their problems, and testosterone is not going to solve the effects from your shitty diet, from your poor sleep schedule, from your bad relationship, from your work and home stress, and all of these other things. It can make them feel a little bit better in some cases, but like it's not a panacea, right? It's not a panacea.
You kind of touched on it in the Nandrolone discussion, but I want to kind of touch on risk mitigation a bit. Whenever you're saying work with somebody to make sure things are controlled, what I see with that is like, a tight blood pressure, not just, 140 over 90 is okay.
It's not okay.
No, we need to, if you're going to be straying out, we need to be tightly controlled. Lipids, don't let your, again, this could be a whole discussion on itself, but lipids themselves are not going to be the thing alone to cause heart disease, but you are setting yourself up to have a negative environment where those abnormal lipids are going to contribute to worsening heart disease.
Absolutely.
So it's like those need to be managed, and then kind of like what you're saying, then like let's get an echo, let's get a baseline EKG.
Absolutely.
Let's get a calcium scan if you want and see what your baseline is. Are we starting with a calcium score of 400 or something obnoxious? Right.
Which unless you check, you don't know. That's the thing. Unless you check, you just don't know. So yeah, that's. I mean, honestly, my advice for people that are using those kind of high doses of androgens, it's kind of the same advice like in my practice. Like even if you came to me and you're not on androgens, and you just want to have a long, healthy life, like there's some boxes that need to be checked. Those boxes need to be double checked if you're going to go down that road. And the reality is like the vast majority of guys, they're the gym bro, like you talked about. That guy, like, has he ever stepped into a cardiologist's office? Has he ever had an echo? Does he ever? No, he's just like going for it, man. He's YOLO.
Yeah. Exactly.
And whatever, like if that's you want to do that, go ahead and do it, but I wouldn't recommend it. So, but yeah, like I have drugs and protocols and strategies that I recommend to guys who are going to go down that road. If you want to talk about that, there's some interesting off-label uses for standard drugs that you and I use in our other medical practices that, potentially can benefit guys. So I don't know if you want to talk about that. We can talk about that a little bit.
We can do it briefly. We've already been chatting a bit, but like help prevent the cardiac remodeling and that kind of stuff.
Yeah. So, if you want to, if you're a provider out there, even if you're not, like if you want to get an interesting read or perspective on what long-term, like high doses of androgens can do, like you can find the autopsies in the public domain of some of these famous bodybuilders and athletes and like professional wrestlers that have died prematurely. And there's some universal things that is on every single one of those autopsies, right? So the majority of them have severe atherosclerosis, triple vessel heart disease. The vast majority of them have, scarred and sclerotic kidneys. And almost 100% of them have left ventricular hypertrophy or cardiomegaly. And not just a little bit, like,
yeah, I remember your video.
Amounts,
it was
right?
Like Rich Piana's was like 5,000. It
was like
or
a
something.
Freaking basketball, right? All of it. Like Dallas McCarver, his heart was huge. The Ultimate Warrior, huge, thickened heart. And so that's what you see, right? So there's ways to. I'm not going to say that you're not going to still develop that to some degree, but like there's strategies that you can take to hopefully, mitigate some of that. Again, there's no studies on these guys. There's no studies on any of these drugs that I would mention can I prove that that's going to prevent, if the Ultimate Warrior was my patient, 10 years ago or 20 years ago, could I have prevented his early death? I don't know, but I have a feeling it certainly could have delayed it, if he had been monitored properly. So, ACE inhibitors, ARBs, everybody likes telmisartan. I love telmisartan too. It goes well beyond its blood pressure lowering effects. It seems to slow the progression of atherosclerosis. It helps, you mentioned nitric oxide, which I love hearing you say that. It's super, super important. It increases nitric oxide in the small vessels. I think that's going to be a staple for most guys, even guys that have borderline blood pressure elevation or maybe even no blood pressure elevation at all. I think you could make a case for a very low dose of an ACE or an ARB, especially telmisartan, as long as you're not making them hypotensive, which is really probably never going to happen. I think there's enough health benefits. Like I don't have hypertension. I take telmisartan. I've been on telmisartan for over a decade. I was on telmisartan before it was cool. Because I ran into some of the early studies on it, and I was like, this sounds really promising. So I've been taking that for a long time. I'm big on, and I've gotten bigger on the SGLT2 inhibitors. So
nice. Yeah, I honestly forget about them, but they have tons of cardiac
great data,
MACE.
right?
Yeah.
Right, and great data in mitigating and in some cases reversing left ventricular hypertrophy. And not only that, but also being like kidney and cardiac protective. So I really think, and there's a paper that came out like a year or two about this, that I think that they are probably longevity drugs. Like they're potentially like genuine anti-aging drugs. And
they're gonna be a lot better than metformin for the
way better. And they don't just act at the kidney. They act in the CNS. They act in all sorts of places that you wouldn't expect. So super interesting. I really think that that's probably going to be a staple of anyone who's into like longevity. Again, we're talking low doses. We don't have to talk about big, like we're not treating type 2 diabetes here, but we want to reap the benefits of these drugs. And I think the SGLT2s are pretty interesting. Nebivolol is another really interesting drug. Again, for mitigating LVH. You like I like it too. Again, it's the nitric oxide releasing properties of nebivolol are fascinating. Nebivolol is anti-inflammatory. It reduces superoxide dismutase. Some of these free radical substances that are toxic. Yeah, it does. I'm going to drop a big video on nebivolol. Just give me some time, and I'm going to put it out there. And some of the ways that nebivolol works, I think, will surprise a lot of people, even clinicians that use it for a long time. I actually learned some new things about it in terms of making this in the process of making that video. But it's a highly cardioselective, so it hits that beta 1 receptor, and so it also vasodilates, and so it's pretty good for blood pressure lowering. Like the older, like certainly first and second generation beta blockers are not great for just hypertension themselves. They do lower blood pressure, but they're better for people that have heart failure, and they're sort of second and third line. But nebivolol, you can put that right up there. It's very well tolerated by athletes, for a lot of reasons. But it hits a lot of the things.
Reduction.
Yeah, exactly. So it's a special kind of third generation beta blocker. So, but the thing is, like, in order to get on those medications and to have them dosed properly and you need to be monitored on those. Like you need to see somebody who knows what they're doing. So I guess that's probably like the take home message of this entire podcast is, if you're going to go down the quote sport TRT route, or, if you're a full blown going to do cycles, just see somebody who knows what they're doing, see somebody who can counsel you about it, can give you some objective baseline information, and then monitor you properly so you don't kill yourself. Essentially, right? And unfortunately, like I said, it's kind of hard. There's not that many providers out there that know enough like general medicine, but also know the, that anabolic TRT bodybuilding world too, and can like put the two together. So those kind of folks are few and far between, unfortunately. Yeah. But if you look hard enough, like you can find somebody. Do not, like your patient did, do not rely on your gym bro, because your gym bro, and even if they have a YouTube channel, that doesn't make them just having a YouTube channel doesn't make you a medical authority, unfortunately.
That's what I was going to say too. I should have had my shirt off at the beginning, because that
we should have coordinated to have our tank tops on and be in our basements. Now we're more.
I mean, I don't have the I'm not cut enough to feel confident about it, but I feel like that's how you
stay covered up too.
Yeah, shirtless and 30%
but there's
off
so
my
much.
peptide
There's so
stack.
much noise. There's so much bad advice being put out there by people who sound credible but have no credentials, no training, and no clinical experience whatsoever in taking care of any of these things. You and I didn't graduate school and jump right into TRT. Like, we have had full careers taking care of like really sick people with serious medical problems, and I think having that background really helps. It really helps when you move into this space, because you understand the pathophysiology really well. And as opposed to somebody like a gym bro who knows literally nothing other than what they study on the Reddit forums and they hear from their buddies, or somebody like who's fresh out of school, right, and just doesn't have the clinical experience. So find somebody who's good. I know it's hard.
So, I mean, you did a good job wrapping up. I want to end on something just a little lighter. Like, do you have any cool ER tricks that are like kind of uncommon? Like, I was going to give my example for oral bleeding. I'll put a tea bag in their mouth and get them to bite down on it. And it is surprisingly effective.
Yeah, I've heard about that. I've never tried it. I've done it.
I've done it a dozen times and it works well. And then I get to say, hey, I teabagged that patient. Will you check on him in a little bit? It gets a laugh like 10% of the time from the nurses. But, it's like I laugh on the inside
that's funny.
every time.
That's genuinely funny. Yeah.
Do you have any ER tips or anything?
Okay, I can think of one. I don't know how much, really, if this is a tip or not, but a colleague of mine had and I had heard about this and like forgot about it, but a colleague of mine had somebody who they were coming in with a pretty severe migraine, right-sided, they were pretty bad. They were very needle phobic and adverse. So, there's a cocktail of drugs that I like to use for acute migraine that's super effective. But, not everybody is down with that. So what this very smart provider did is they did a stellate ganglion block fixed the headache immediately. Have you ever done this? So you take one of those long Q-tips, and you soak the end of it in a topical anesthetic, lidocaine, bupivacaine, whatever, and it's inserted directly back, and you leave it in so like the Q-tip is, the wooden part is sticking out. It's not one of the short Q-tips, right, that you can buy over the counter. It's one of the long ones. Yeah. And then you just put it in there and you insert it until you hit resistance. And that's roughly where the stellate ganglion is. It's a nerve cluster that's, involved in migraine headache propagation of pain. And it worked like a charm. Yeah, it worked. So there was no IV. Cool. Yeah, super cool, right? So, and I'm like, I've totally forgotten. I'm like, I need to start thinking about this. Because it's something like if somebody comes in and they're just vomiting and they're miserable from a migraine headache, it takes some time to get the IV in. You got to go get the meds, and then it takes a little time. This is something you can just do quick at the bedside while you get that other stuff ready in case it doesn't work. And, many times it does work. So I guess that's like the one cool thing I saw recently that
nice.
Like I'm actually
the migraine, my migraine cocktail, I mean, I like compazine, chlorhexidine, and Benadryl and
that's what I
it
do.
makes them so drowsy that they have to have a ride home and everything.
Sometimes,
but I'd actually, the first time I ever tried it was a nurse on staff. She was working, and she was like,
Perfect
I don't want
indication.
anything sedating, and we always have lidocaine everywhere, in the
Exactly.
ER. So it's like,
Yeah.
let's just try it, see if it works. Because I listened back in the ER, I'd listened to like every MRAP episode.
Yeah. That's a good one.
And
Good show.
and they had just talked about it. So I was like, well, let me try this on you and see. And I didn't do the big long Q-tip. I just did a nasal atomizer of it.
Oh, sure.
And
Yeah.
she got good relief
cool.
from it. Enough to
Yeah.
keep working, not sedated.
Exactly.
So it was good.
I don't know what what the efficacy is, like what percentage of people respond to it, but it's, again, getting back to like our previous statements, the probability of harming someone, unless you like ram that thing in there, is
nothing.
like pretty much zero, right? So like, why not give it a try? Why not give it a try? So that's, I guess that's the only, I've had a lot of weird cases lately, but that one, that little pro tip, I'm going to actually use that from now on.
Yeah. Nice. Yeah. I love hearing any of this stuff. I've been out of the ER. February last month was 4 years since my last shift, which sounds crazy. I feel like it was yesterday and a lifetime ago at the same time.
For sure. It's an interesting place, man.
Thanks so much for coming on.
Oh, of course, anytime, man. We'll make it happen. This is an important topic. Guys are interested in it. They need to know about it. And if they have questions, leave them in the comments.
Yeah, and appreciate your time. And we'll meet up again at some point.
Sounds good, brother.